Good afternoon, everyone, and welcome to the second edition of the COVID-19 webinar on this theme, Flattening the COVID-19 Curve in Cameroon. This time around, we're focusing on perspectives from clinicians and researchers. So today's webinar is going to be moderated by Dr. Ronald Gobina, and our rapporteur will be Odette Zemo-Kibu, who is Health Policy Analyst at the Nkafu Policy Institute. So, Dr. Ronald Gobina, over to you.
Thank you very much, Ansel. Welcome to everybody. We're happy to have you. We're honored to have our panelists, our special guests, who are going to be resource persons for our discussions today. We recognize the presence of Dr. Temgwa Mazu, Jeanette Atem, Dr. Mark Keboa, and Dr. Kevin Kaje. We are so honored to have you. We're going to go straight into our talk and our discussions. We have a problem. It's not a Cameroonian problem, it's a worldwide problem. And things don't seem to be getting better. If we are going to see an improvement with respect to the coronavirus pandemic, we need to join forces. We need to think together. We need to brainstorm together. And that is the reason for this gathering, for this convocation. So we'll expect participants not only to listen, but where you have pertinent suggestions, pertinent questions, to record them, because we'll get back to you to take your questions and discuss together. And we're hoping that by the time we're done with our webinar, we have a better idea, we are better armed to deal with this pandemic, and why not, we have an interesting topic or take for a subsequent webinar, which is going to be sometime in the future to be announced. So we're going to go straight away. Jeanette, I'm going to index you directly. I'm going to start with you, and I'm going to ask you a question which may be a little bit personal.
Sure.
I know you're a nurse, and I know you're on the front lines of the fight against coronavirus. Since this pandemic began, have you at any point regretted being a healthcare personnel? Have you at any point questioned whether you're in the right place, whether you're not risking yourself unnecessarily?
No, because I love what I do. And when you're right there in the front line, I work in the emergency room. When you see what people go through and just being there to help, to save a life, to me, that's rewarding than anything else. No, I've never regretted being a nurse.
Thank you very much.
It's got harder, but no, I still love what I do.
Thank you. I think this is one of the success stories we need to highlight in this pandemic, is that no matter how hard it is, no matter how many health personnel have fallen on the battlefield, we are still committed, we're still engaged. We want to see our patients back on their feet. We have a lot of numbers. In Cameroon, the numbers are increasing. We say about 2,000 cases in about a month, new cases. It's horrible. This webinar wants to look behind the numbers. We all know the numbers, number of deaths increasing, but behind those statistics are real human beings. Our parents, our brothers, our sisters, who have a name, and they are not just figures. And as a frontline person in contact with those people, Jeanette, what is their story?
Sorry, can you get, I didn't get your question.
The question is, behind the numbers, behind the figures that we have, you are dealing with real human beings who have their own fears, who have their own understanding. Some of them accept, some deny the diagnosis. on that interaction behind the curtains, behind those numbers, what is your take? What is your impression?
Well, when it all started, I think so many people were in denial, especially when we put them on isolation. Because what we do is at the front line, usually when you come to the hospital, there is that first place where you get to the first nurse. It's called the triage. But when the cases became more, we had to do like a pre-triage. We had to close the main entrance. You have to come in through the garage. You're asked if you've been in contact with any person who's had COVID-19 or who's traveled out of the country. That were the first questions. The second, if you had temperature, you've been sneezing, coughing, or having respiratory difficulties. Those were the initial questions. Some people say, no, 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 no. And let me tell you, it was really difficult to pick it out. It was really difficult to separate who is sick, having the COVID symptoms, and who is just sick, like the normal illnesses. Yeah, some people will say, no, I've not had contact with anyone else, but then a family member visited them. I'll just give you this example. We had an old lady, she came in, she was fine, breathing normally. Then, like within 3 hours, everything escalated. She spiked a fever. We put her on oxygen, but she wasn't breathing well. She kept going down, becoming very, very ill. So we had to take her and intubate her to the corona and intubate her. It's only after 24 hours that this daughter called in and said, oh, by the way, my brother is a truck driver who travels from Canada to the US and visited my mom the last 10 days. But this is the information that we did not have in the beginning. So just imagine that trail from when she came in. People were not prepared. You did not put on your mask. You did not put on your protective equipment. Along the line, that was a great spread. Why did this happen? Because this woman was in denial. She did not believe that she was having COVID. That's one of the things that led to the rapid spread of COVID-19, because so many people were in denial. But nowadays, anyone who walks in through the door, you are considered a COVID patient until proven otherwise.
Thank you.
That's what we are doing, trying to de-escalate the spread, and it's working. It's working. Where I work, I'm in one of the hospitals. It's called the hot zone. So we are specialists in the COVID patients. Even when people are tested elsewhere and they're very sick, they're being transferred to where I work.
Okay. Dr. Temkwa, Jeanette works in the USA.
No, I'm in Canada.
She works in Canada, and she's saying even Canadians have some level of denial, and they've been fighting through it. Dr. Temkwa, you work in Cameroon. Is it the same story? Is it worse? We have heard on social media and on national TV stations that people run away from hospital. Is it the same story? Are people in denial in Cameroon, and is that changing in any sense?
Okay, thank you, Dr. Gobina, for giving me the floor, which will explain more a little bit in French. So, effectivement, après avoir entendu l'histoire du Canada, c'est pratiquement la même histoire qui se vit. C'est-à-dire que on est en permanence sur le choc quand on se rend compte que les médias sociaux essaient de vulgariser l'information, mais beaucoup de personnes sont tout de même très stressées quand ils apprennent qu'il y a des uns et des autres qui décèdent et tout. D'autres choses, c'est qu'il faut savoir, c'est qu'on se rend compte qu'effectivement, que beaucoup de personnes sortent des lieux de confinement pour fuir. Pourquoi est-ce que ça se passe comme ça? Mais c'est simplement parce que la maladie est devenue extrêmement stigmatisante. Extrêmement stigmatisante parce que quand on voit quelqu'un qui a le corona, on se dit qu'il va contaminer. Et nous, on n'est plus à l'abri de quelque chose. Donc, quand c'est devenu que beaucoup de personnes ont peur de vivre la maladie. Donc, il faut casser cette barrière de la stigmatisation pour faire en sorte que les uns et les autres continuent à vivre leur maladie et que ce soit une maladie comme une autre. L'autre chose qu'il faut dire aussi, c'est que les gens qui sont même dans les lieux de confinement, certaines personnes se plaignent qu'il y a une cassure avec les barrières, on va dire la culture dont on a l'habitude dans notre contexte camerounais. Vous savez que les uns et les autres se serrent beaucoup les coudes. Quand on dit qu'on ne peut pas rester à la maison avec la famille, ça devient quelque chose de très, très grave. Donc, il faut voir dans quelle mesure est-ce qu'il faut faire une sociale et même familiale, même avec se rapprocher de ces personnes. Lorsqu'ils sentent qu'ils sont seuls, abandonnés à eux-mêmes, ils vont fuir les lieux de confinement. Lorsqu'ils sentent qu'ils sont stigmatisés, ils vont forcément fuir les lieux de confinement. Voilà donc ce qui fait en sorte, en gros, dans notre contexte, que finalement, les uns et les autres n'adhèrent pas à la politique. Pourtant, le confinement évite qu'il y ait une transmission excessive de la maladie. Donc, ce qu'on peut dire par rapport à notre contexte.
Thank you. Thank you so much. Dr. Kevin?
Yes.
You're a public health specialist. You are on the field, you're in the community. Maybe Dr. Temgwa is more in the hospital as Jeanette. Is it the same problem? Are people in the communities in acceptance of this problem? Or do you still have people who tell you, c'est sans vos choses?
Thank you, Dr. Govina, to giving me the floor. Good afternoon, everyone. As the Dr. Temgwa will answer in French. Alors, en communauté, nous avons énormément de problèmes, évidemment, surtout dans la gestion des décès. Lorsque nous avons des décès communautaires qui ne sont pas donc étiquetés. Et pendant l'investigation, on arrive à avoir des familles qui vous disent non à toute question concernant les symptômes COVID. Donc, on a du mal donc à retracer l'histoire de ce malade, de cette personne avant son décès. Et également, dans la communauté, quand nous envoyons nos agents de santé communautaires, parfois, ils ne sont pas reçus comme il se doit pour recevoir les conseils sur les mesures barrières. Donc, il y a quand même encore un rejet. Certaines personnes qui disent non, c'est pas vrai, allez avec vos choses. Peut-être le gouvernement vous a payé pour que vous nous apportiez vous-même la maladie. Donc, il y a encore beaucoup de problèmes dans la perception de la maladie. Et je pourrais dire que, en fait, les personnes sont influencées par les informations qu'elles reçoivent, que ce soit sur les réseaux sociaux, que ce soit les informations officielles ou encore de leur propre vécu. Et quand on fait peut-être la synthèse de ces informations, ben, ce qu'il en résulte n'est pas très rassurant pour le profane, pour la communauté. On se demande donc s'il ne faudrait pas réorienter un peu notre communication, notre sensibilisation, et pourquoi pas prioriser les témoignages des personnes guéries pour enlever un peu cette psychose dans la tête des personnes qui croient que Covid égale mort. Donc, j'ai l'impression que les populations, les profanes seraient plus intéressés, par exemple, de suivre quotidiennement le témoignage d'une personne guérie et non l'interview d'un chef de district comme moi ou d'un directeur de la maladie ou d'un ministre. Donc, peut-être, ce serait une solution pour déstigmatiser un peu la perception de la maladie chez les populations.
Thank you so much. I love your suggestion, and I think we need to develop this, especially in the context of our task force. Getting testimonies from cured people.
Yes.
Powerfully. Thank you so much. Jeanette, I know you're going to be running in a while. I need to talk to you.
Sure.
You're in a different context from Cameroon,
Yes.
Economically speaking, technology speaking. And I'm sure you know that we are limited in many ways.
Sure.
What is your best advice for Cameroon, for our limited setting, to improve clinical outcomes? I mean, taking care of the patients in the hospital. How are the treatment teams organized? Do you have, yes.
Well, like the first thing is isolation.
Okay.
Isolation, and that can be done in Cameroon, in Canada, anywhere in the world. It's just isolation, like keeping the patient at least 2 meters apart. Yes, I know in terms of equipment, like the personal protective devices, it's limited in Cameroon, but they are just the basics, like using a face mask or a shield. That is very important. Like, you know, the COVID virus is a droplet. That it means that the virus is really big to be carried in the air. If that patient is not on high oxygen or is not intubated, there is no need for you to put an N95 mask. That is what really filters the air. So if you don't have a mask, a simple face cloth is sufficient. Trust me, even in Canada, we are running out of equipment. So what we do is we take regular cloth and we make a mask. Just give me a second. I'm just going to show you one thing I made. Like this. This is my hat. As you can see, this is African fabric. So even in Canada, we ran out of head scarf. I mean, us in the emergency. So what we do is we take our own personal tissue and we make it into mask. We make it into hat to prepare. The only thing you have to do is after use, wash it with water and dry and reuse. If you don't have a mask, I'll say it's a head tie is sufficient. Put it over your nose and your mouth. That will prevent the droplets. Keep distance 2 meters apart. That can be done anywhere. I think like the speaker that just spoke before me, sorry, I didn't keep the name. She said it's a matter of the people to agree. So for people must accept that there is coronavirus. We can do this by educating them. When they accept that there is coronavirus, then despite the minimal resources, they can still protect themselves. And by so doing, it's really, really gonna decrease the curve. That's what I can say.
Thank you so much. Dr. Keboa, Mark, tell us a little bit of your story in terms of being on the front line. I understand that you're an oral health expert. What word do you have for Cameroon? You're based in Canada.
Yeah, thank you, Dr. Govina, for the opportunity to share my views on this important topic. I think first thing we need to do is explain to the population in simple language that COVID-19 is real and everyone has a role to play to reduce the spread of this virus. Because if we see it as a public health issue, then people will tend to say, okay, let government do what it has to do. If there are regulations, which I know we have very bright and capable people in Cameroon, they have these regulations in place. There's that gap between the regulations and implementing these regulations. So there has to be discussions with all sectors, everyone involved. How do we facilitate, make it easier for the population to understand the severity of this disease? How do we make it easier for people to keep their children at home? Because it's one thing to say we've closed down schools and the next place all kids converge is in the market. So that defeats the purpose of closing down schools. So all sectors have to discuss how do we make sure that we are able to translate these regulations that are proven to prevent the spread of COVID to make it feasible for the population. With respect to Cameroon, I think the people on the ground understand best the context and the challenges. This is not to say there are not challenges that are experienced in developed and in developed countries, but I would not want to transfer immediately challenges or opportunities in Canada to the context of Cameroon. That said, there's always a lesson we can learn from other countries and see how best to adapt it to our context to limit the spread of the virus. Because it is only when we are able to have a control over the spread of the virus that our healthcare system will not be overwhelmed. We know the capacity of our healthcare system. Some of us have worked in the system for many years before leaving. So we do not need to overwhelm this system. Let everyone be responsible and play their role to make sure that only those who are very sick get to the hospital, and that when they get to the hospital, our healthcare workers have the appropriate materials, they have the appropriate equipment to provide best care to those who are affected by COVID-19. To go back to what one of the speakers said already, the issue of stigma. We need to learn from lessons from past epidemics or past infections. For example, HIV/AIDS is a good example. What lessons can we draw from stigma control measures from HIV/AIDS that can be useful in the current context? Because if someone who is affected by the virus or has coronavirus symptoms is stigmatized by the population, then the person may not have the capacity to be isolated, may not have the capacity to follow the public health measures that would in turn limit the spread of this disease. Collectively, I say, collaborative measures, very important. Government, private sector, the population, NGOs, everyone needs to be on board. And we should see this as a common enemy and not an issue that is imported from somewhere and that the government has to resolve. This is my little contribution for now.
Thank you, Mark. My next question just continues from some of the points you raised, policy, collaboration. And this question, I'm throwing it at everybody, at all the panelists. Have you encountered, or do you have the impression that there is synergy between policy from the public health experts and the clinicians? Are the clinicians trying to do their own thing? They want to do scans for everybody and use the clinicians' hunch to diagnose cases? Are the public health specialists very narrow in their perspective of management? What do you think is there a conflict between hospital management of cases and a more broader management of the pandemic?
If I may, moderator, if you may permit me to jump in here.
Yes.
I think in our strategies, there's need to be transparency and effective communication at all levels. Because in these days, we receive information from all sorts of avenues, information that is unverified through social media, information that has no basis, and people are confused. So people even doubt the measures that are proposed by our own public health experts, if this is really true. And if people start questioning information that, measures that are put in place, then we are not going in the right direction. So one, we need to put in place an effective communication strategy. We need to be transparent at all levels. For example, if a family loses a client in hospital and the corpse is being retained that this person died of COVID-19, and they were not aware that even a test was run for their family member, that raises a lot of questions. So just to say we have good policies, I have no doubt we have enormous human resource capacity in Cameroon. It is just how to better collaborate our actions, be transparent in our measures, make communication simple and clear and efficient, get the support of the community, of the population, which is very vital in preventing the spread of this virus. And then I think we will be in a good step towards flattening this curve.
Thank you. Kevin, any word? How can we strengthen the tie, the communication, the synergy between the public health experts and those in the hospitals, touching cases?
Okay, permit me to answer, like, just, I know I'm not in Cameroon, but like one of the speakers said, if we see something from another country that is good and is improving the situation, then we can also follow as a good example. I'll take the case here in Canada where I work. We have a team of researchers which come out with strategies how to manage COVID-19. Like every day we have updates. Once there is an update, we receive emails every shift. At the beginning of every shift, we have 10 to 15 minutes meeting on how to manage that. This is the new strategy. And it's not only where I work, it's like, it's distributed in the whole of Quebec. So like we have a common procedure to follow, how to treat COVID patients, how to educate those who are not very symptomatic and can go back to the community. We have a handout we give to patients who are tested positive, but are well enough to stay in the community. And there is a list of things to do to isolate themselves, how to manage their affairs out of the hospital in the community in order to prevent the spread of the virus. I think if in Cameroon, which is very, very possible, we implement something like this, it will be like a model. It's not like, oh, in Yaoundé we are doing this, in Douala we're doing this, in Bamenda we're doing this. No, like we have that one unit that when we have that information, we distribute it. Thank God to public media today, in seconds, in minutes, we can release all that information all over Cameroon. And I think if that is done and we follow it, it will help us a lot.
I think you've said something so powerful, Jeanette, and it's amazing. From what you've just said, it's not necessarily the administrators. You have researchers who are concerting to publish updates, yes, which you use for your briefings before, yes, every shift. Dr. Mazu, I'm not sure that is happening in Cameroon, or I don't know in other African countries, but it sounds like something we need to start looking into, where decision-making clinical practice can evolve based on evidence. So the question we will ask ourselves for Cameroon is, how do we get evidence generated in Cameroon or generated elsewhere to the clinicians in the hospitals and make sure that it's part of decision-making to guide clinical practice? Any words, Dr. Temgwa? Is still on? I think we've lost Dr. Temgwa for a minute. You strengthening the tie, the communication and the collaboration between policymakers and clinicians. I'm sure we have had we've had events and social media talking about hitting on doctors, or doctors having a certain view of how the pandemic should run. What would be your advice as a public health specialist to your colleagues and to us who treat the patients?
Is it a question for me?
Yes.
OK. Alors, je pense qu'il y a beaucoup d'efforts qui sont faits dans le sens de mettre ensemble les cliniciens et les décideurs politiques. Nous avons déjà la mise sur pied des comités scientifiques dans les grandes villes qui sont actuellement touchés par la pandémie à Yaoundé et à Douala. Je n'ai pas encore assisté à ces réunions, mais il y a quand même un effort de se retourner vers les politiques parce que c'est effectivement les cliniciens qui gèrent le volet de la riposte, qui est la prise en charge clinique et donc qui offre en termes de capacité d'accueil, en termes de protocole de prise en charge et autres. Donc, les résultats de leurs assises sont très souvent partagés aux politiciens et également les politiques. Est-ce qu'ils prennent en compte les capacités d'accueil? En principe, oui. Nous avons vécu tour à tour les premières barrières, les premières mesures de barrières édictées par le gouvernement. Ensuite, contre toute attente, nous avons eu leur allègement. Donc, on est en droit de se poser la question s'il y a effectivement un pont entre les deux. Nous pensons que chaque système évolue beaucoup plus de manière cloisonnée. Il faudrait vraiment améliorer la collaboration entre les deux pour plus d'impact dans les mesures. Par exemple, au niveau du district de santé, nous avons encore d'énormes problèmes. Nous vivons la décentralisation de la riposte au niveau communautaire et on a encore beaucoup de gaps à notre niveau qui n'ont pas encore été vraiment adressés, à savoir ces problèmes de dépistage qui font encore défaut dans la communauté. Nous avons des difficultés dans les ressources financières et même logistiques quand on sait que la transmission est déjà communautaire et qu'on devrait justement améliorer le dépistage pour une prise en charge précoce et surtout quand on sait que les hôpitaux sont débordés en termes de capacité d'accueil. Donc, il est important de rapidement renforcer ce système opérationnel de riposte pour moins mettre la pression sur le système de santé. Et cela demande justement une bonne collaboration entre les deux parties. En outre, au niveau des formations sanitaires, on a la technicité, on sait comment prendre en charge, on sait comment organiser le triage des malades, mais est-ce qu'il ne faudrait pas également, je dirais, libéraliser la prise en charge? Si le politique est au courant de cette pression du système de santé, est-ce qu'il ne faudrait pas arriver à libéraliser cette prise en charge? Car tout médecin peut diagnostiquer un cas de COVID, peut prescrire un bilan initial, un bilan de suivi, peut prescrire un protocole, surtout pour les formes légères. Ça fera en sorte qu'on prendrait vite en charge les personnes, on arriverait moins aux formes critiques et on mettrait moins de pression aux services de réanimation qui ont des déficits en lit. Donc, il est vraiment urgent de reconsidérer peut-être la stratégie qui a donné uniquement aux centres agréés la prise en charge du COVID. Est-ce qu'on ne pourrait pas décentraliser également, comme on a vécu avec le VIH? Nous sommes arrivés à ce que les ARV soient dispensés par les communautaires. Donc, le COVID, on va apprendre à vivre avec les mois, voire années à venir. Donc, réfléchissons pour que les politiques comprennent qu'il faudrait, pour moins mettre de la pression au système de santé, libéraliser peut-être la prise en charge. Et comme ça, avec une ordonnance prescrite par un médecin, avec un résultat positif, on se rendrait maintenant peut-être vers un centre agréé pour recevoir son traitement gratuit. Donc, quand on n'y est pas, on comprend que les secteurs politiques et sanitaires évoluent vraiment en vase clos. Chacun essaye de gérer son petit coin, mais il n'y a pas véritablement de pont pour prendre des décisions collégiales et des décisions qui soulagent tous les deux secteurs et surtout la population. Vous disiez tout à l'heure que derrière les chiffres, on a des personnes, on a des décès. Donc, il faut vraiment reconsidérer au jour le jour nos politiques en fonction des résultats que nous recevons.
Thank you so much. I really am in love with your proposal. I think it is practical, and I should remind us, Dr. Kajer works in a hot zone. She's the district medical officer in charge of Japoma Health District. That's in the littoral, and we know the number of cases in the littoral region. So she's speaking from experience and suggesting a different policy approach in terms of managing of cases. I think we need to record that and communicate that to the highest quarters possible. She's seeing so many cases in her community, meaning she's learning a lot, learning fast, and we need to listen to them. Janet, you mentioned that in what people are doing over there, things are improving. You
Yes.
mentioned that things are improving. Are you seeing a win in the near future? And what do you think is the most powerful thing, or the two most powerful things that have contributed to that?
First is awareness. People are now accepting the fact that COVID really exists. Awareness. And like I love the way she mentioned my previous speaker. What also it's improving, it's early identification and isolation. Like here, everyone who has a symptom must not come to the hospital. They are COVID centers. This is when you have a fever, but you can walk, you can talk, you can function. You go there, you do your COVID swab, you go back home, they give you the COVID guideline, how to live in the community. That really, really decreases the number of people who come to the hospital as we have no beds. Another thing, it's we try to practice, we try to practice the social distancing, the isolation, and there is education every day in every media, in the billboards, on TV, what to do, radio station. I think if we try to sensitize the public by passing out this message, they will come to understand that truly this exists. But she also talked about stigmatization. Yeah, I know it's back home, but I think if people hear this over and over, that COVID is just an illness like having hypertension or malaria, they'll come to know that, oh no, it's a disease that we can manage, that we can live with it, that we can prevent it by carrying out the preventive measures like any other diseases. I think if we do these two things, it will help flatten the curve.
Great, thank you. Dr. Temgwa, we all agree, healthcare workers are the front lines. They are exposed, but they're also the ones who are helping to make things better overall. And it's important that in their endeavors to improve things, they are not victims. We have already recorded so many cases. The case fatality rate in Cameroon is highest amongst healthcare workers than in the general population. Doctors, nurses, lab technicians, all those are the front lines are at risk. My question to you, I know you have, you lead a team of doctors in Yaoundé who have been helping this patient, and you have a lot of your efforts to provide PPE for them. Can you tell us a little bit about that? How are you doing it? I mean, without government assistance. And if some well-wishers on this webinar are to put in a hand to help you, how do you think they can come in?
Okay, thank you, Dr. Gobina. Alors, déjà, je voulais m'excuser par rapport à les coupures de tout à l'heure là, qui étaient indépendantes de ma volonté. La connexion était un peu instable. Et comme Dr. Gobina l'a dit, et comme on peut le remarquer à travers les chiffres sur le plan épidémiologique, on sait que le personnel soignant est au four au moulin et c'est le plus exposé dans cette maladie, la COVID-19. Ce que nous avons essayé de faire actuellement, j'ai eu la chance d'être leader de l'association des résidents de médecine interne et spécialité et de l'association des résidents et internes du Cameroun. Ce qu'on essaie de faire à notre niveau sans forcément attendre le soutien gouvernemental, c'est qu'on est conscient que c'est une maladie pour laquelle chaque individu doit pouvoir dire que ce n'est pas une affaire d'autrui, c'est une affaire personnelle. On doit prendre ça personnellement. Pour ça, nous, on a essayé de rédiger certaines demandes auprès des différents sponsors que nous avons, certains laboratoires, certaines firmes pharmaceutiques, etc., pour essayer d'approvisionner les résidents et les internes en matériel de protection. Parce qu'on ne peut pas s'exposer comme ça, étant conscient que nous sommes déjà exposés. Si on s'expose davantage et qu'on n'a pas de moyens de protection, ça va être un frein déjà pour la lutte contre cette maladie, parce que vous imaginez bien que s'il y a réduction du nombre de personnels soignants, personne ne va plus être...
I think we have lost him we've lost his connection.
Okay. Dr. Gobina?
Yes.
Yes, justement, si je peux prendre le relais concernant cette question du personnel qui est très, très sensible parce que, évidemment, le système de santé et son personnel entier jouent actuellement un rôle prépondérant dans la lutte contre le COVID. Il est important que des mesures spéciales soient prises pour les soutenir et les protéger. Dr. Temgwa nous a déjà dit concrètement ce qu'ils font et quelles sont leurs difficultés, surtout l'acquisition des EPI. Je crois qu'il est important que tous les managers considèrent 4 points pour maintenir le personnel en forme et sur pied durant cette riposte qui s'annonce longue. La première chose qui est déjà presque un acquis, c'est la sécurité du personnel qui passe donc par la formation sur la maladie COVID elle-même et la formation sur la protection et le contrôle des infections, qui est la PCI. Ici, au littoral, nous avons la délégation de la santé appuyée par l'Organisation mondiale de la santé qui organise des séances de formation sur ces 2 thématiques. C'est important pour que le personnel comprenne comment on se contamine et comment on se protège. Également, il est important, toujours dans ce volet sécurité du personnel, d'améliorer le dialogue entre les personnels et leurs responsables. Parce qu'on ne devrait pas transformer les gens en robots qui viennent tous les jours, travaillent et ne voient pas à un moment donné les résultats de leur effort. Donc, il faut améliorer le dialogue entre le personnel et leurs responsables qui doivent à un moment donné leur dire voilà à quoi on est arrivé après une semaine, après 1 mois, après 3 mois de lutte acharnée dans notre contexte de l'hôpital ou de la région ou du district. Le deuxième volet que je trouve important, c'est la protection de leur santé mentale. On a longtemps parlé ici de stigmatisation, de discrimination. Qu'on sachait que le personnel dans la ville est discriminé parce qu'il y a une crainte du public de contracter la maladie. Donc, dès qu'on a déjà localisé un personnel qui travaille à la Quintini, même le boutiquier l'évite, les voisins les évitent. Donc, il y a cette stigmatisation. Le personnel doit gérer en plus leur crainte de contracter la maladie et il faudrait donc qu'on protège leur santé en leur donnant des conseils et des astuces pour gérer ce stress. Troisièmement, je pense que ce qui est négligé malheureusement, c'est le suivi des heures de travail. Je vois le programme des collègues à la délégation dans les hôpitaux. C'est un programme fou et je me demande si les gens vont tenir sur la durée. Il est important qu'on prenne en compte le surcroît de travail parce que, savez-vous, depuis l'arrêt de l'école, mais les enfants sont sous la responsabilité éducative de leurs parents. Alors moi, personnel de santé, j'ai des heures de service à honorer, j'ai des responsabilités familiales et j'ai également mon bien-être qui doit être une priorité. Donc, il faudrait que les managers prennent en compte les heures de travail et qu'on fasse un réel suivi de ces heures afin qu'il y ait un équilibre entre ces 3 obligations auxquelles les personnels doivent faire face. Et enfin, la motivation. Le personnel doit rester motivé. Il y a déjà cette motivation intrinsèque parce que s'il y a des gens qui ont abandonné la prise en charge, il y a d'autres qui continuent parce que ces personnes veulent vraiment faire quelque chose pour leur pays. Maintenant, la motivation extrinsèque est importante. Ça passe par tout ce qu'on sait, surtout des motivations pécuniaires ou des reconnaissances de tout genre. Donc, je pense que ces 4 volets doivent être vraiment mis au point dans chaque structure qui emploie du personnel impliqués dans la riposte.
Thank you so much. I think you have put the icing on the cake with your recommendations. I take a lot of powerful messages from our discussion. We are running towards the end of our webinar. We would like to take questions if there are any. Please forward your questions to the rapporteur or write in the chat, and we will be able to forward your questions. If you have a pertinent comment you want to make, raise your hand and we can allow you to say a few words. But I take a lot of messages out of our discussions. One of the highlights is testimonies from cured people who do magic. So we want to encourage Dr. Kevin and everyone else on the front lines to recruit cured people. And we have the platform in the Nkafu Policy Institute to vent their testimonies on social media, on our website. And so if you need us to get the testimonies out, we are available, and we'll encourage you to use your own means, your own methods or channels to let people hear from those who have been inside of the confinement areas and who are alive after treatment. I also take that we should use simple language to communicate and make people understand. We need to take into account context and challenges. We need to fight stigma. Every panelist has highlighted this. We need to consider modifying policy for better outcomes. So opening up management, not restricting it to certain specialized COVID centers will give us a more rapid control mechanism. We need to increase awareness. We need to strengthen collaboration. Early identification and isolation seems to be the winning strategy in Canada. Why not in Cameroon? So we need to intensify our capacities to test and isolate patients, and training on the disease. I would encourage the district medical officer to, in her network of administrators, district medical officers, and even higher level administrators, to make this a reality. We've not had as much training in my hospital, for example, but we have taken your recommendation and we implement it. A week will not go by without this happening, but what about the rest of the country? We need to improve working conditions for healthcare staff. We need to protect their mental health, and staff need to grow in consciousness and in behavior, not to be laxed, but to take things seriously, especially when they are at the workplace. And we need to manage their working hours so that they are not amazing contributions. We have a questions for Dr. Kevin from René Mendo. Dans le cadre de la réponse au niveau des districts, est-ce que des mécanismes de surveillance à base communautaire impliquent des ASC, I don't know what ASC is, impliquant des ASC sont mis en place pour la détection précoce, mais pas seulement les ASC impliquant aussi, par exemple, des leaders communautaires, des organisations à base communautaire comme la Croix-Rouge.
Merci, Dr. Mendouga Sandrine, pour la question. ASC is Community Health Worker, donc agent de santé communautaire. Et nous avons justement des agents de santé communautaire qui sont déployés à travers les districts pour effectuer une stratégie en porte-à-porte. Et le paquet de communication consiste donc la sensibilisation sur les mesures barrières, mais dans une moindre mesure aussi la détection précoce des cas. Il y a eu plusieurs descentes déjà comme celle-là, et ils avaient même un questionnaire électronique où ils posaient des questions aux populations pour détecter s'il y a des symptômes faisant évoquer le COVID. Donc actuellement, leur rôle principal est de sensibiliser les populations sur les mesures barrières, et s'il y a un cas, évidemment, les encourager à appeler les numéros verts, le 1510.
Thank you.
Pour les leaders communautaires également, ils sont sensibilisés pour pouvoir notifier au district de santé lorsqu'il y a des cas suspects dans la communauté.
Thank you. I think this question, I would like Kevin to say a word, but also Dr. Keboa. If we think into the future, what is the single most important policy reform we can think of that will allow us to be better prepared for subsequent epidemics and pandemics?
Thank you.
Coronavirus took the world by storm, by surprise. How can we prepare for the future?
Thank you, Doctor, for this question, Dr. Denis. I think nous devons sortir grandis justement de ce genre d'épidémie. Et je pense précisément comme politique au renforcement du système de santé opérationnel. Parce que si nous avons quand même flanché dans notre riposte, c'est que les réponses ont été hyper centralisées dès le départ et nous avons procédé à la décentralisation un peu tardivement. Et maintenant, quand on a décentralisé, il se trouve que le système opérationnel, à savoir tout ce qui est organisé autour des centres de santé de premier échelon, des districts de santé, le système est malheureusement faible. Quand on regarde les 6 composants du système de santé, nous n'avions pas un système prêt pour accueillir une telle épidémie. Donc, à l'avenir, on devrait renforcer le volet ressources humaines, on devrait renforcer le volet médicaments, approvisionnement médicaments, finances, gouvernance, voilà, vraiment tous les 6 building blocks du système de santé. On gagnerait vraiment à renforcer tous ces aspects pour que nous soyons prêts à l'avenir à gérer de telles pandémies.
Dr. Keboa, any word?
Yes, so thank you. Definitely we have policies and regulations in place for the current, to fight the current pandemic. I think moving forward, we need to have a proper evaluation of what we did well and what we could improve on. This evaluation should involve all stakeholders in place, from frontline workers to researchers, to traditional rulers, to community leaders, to government. They should have a frank discussion to examine the current situation, and this would inform policy moving forward that will prepare us for the next wave of the pandemic that epidemiologists tell us is almost imminent, or similar pandemics that may be cropping up. We never can tell, but I think lessons learned, what could be done better, feedback into the current policies we have to improve things will go a long way to getting us prepared for the future. Thank you.
We may not have as much time as we would love to take all questions, but I want to throw this burning preoccupation to all the panelists. Schools reopen on the 1st of June. What do you think? Is it time? Are we ready to reopen the doors of our schools?
Hello?
Yes.
Yeah, I think one of the lessons we learned during this pandemic is that there's much we do not know. So decisions are made and always revised. I think for now, I'm not on ground, but I think this is a projection. The authorities that be should evaluate this plan moving forward with evidence that they have on ground to see if this is something practicable. If we are not able to have a control over the spread of the virus, then I think it is something that needs to be put off. But I think any decisions taken for future need to be evaluated as more data, as more evidence emerges. And this is what I think. I think that is just a projection for now. Thank you.
Very well. Yes.
Voilà, concernant cette je suis d'avis avec le rapport précédent. Je pense que craintif parce que on imagine à la suite justement un premier ou un deuxième pic, et on imagine également qu'il y aura une pression sur le système de santé. Mais nous pensons et nous constatons que La propagation continue à cause de l'incivisme, de l'indiscipline des adultes. Une mathématicienne épidémiologue avait été invitée au ministère de la Santé à Yaoundé pour faire une projection en fait des cas. Et il ressortait le 8 mai, quand elle présentait ses résultats, qu'on aurait en fin mai environ 20 000 cas dans la communauté, 5 000 cas diagnostiqués et environ 350 décès. Mais cette projection n'avait pas pris en compte l'allègement des mesures barrières, le long week-end que nous avons connu ici au Cameroun avec tous les déboires et la reprise de l'école. Donc, je pense que comme nous devons vivre avec la maladie, on pourrait penser une ouverture des écoles qui ne sera pas safe sur le long terme, mais parallèlement, le système de santé devrait être prêt à offrir plus de diagnostics, plus de dépistage. Et j'ai vu une question dans la liste des questions qui demande ce que les ONG peuvent faire. Nous avons un sérieux problème de dépistage. On n'arrive pas à aller vers toutes les alertes que nous recevons. Au 10 centre de Jacquemart, par exemple, nous devons attendre qu'un véhicule soit donné par la région pour aller vers les populations. Et nous pensons, et nous sommes en pourparlers avec notre mairie, à installer des postes fixes dans notre lycée de santé pour le dépistage. Parce que ce qui fait défaut maintenant, c'est les moyens logistiques pour faire déplacer l'équipe de prélèvement vers la personne malade. Donc, si parallèlement à la réouverture des écoles, le système peut garantir le dépistage des personnes précocement, la réouverture ne posera pas un grand problème. Donc, si les ONG veulent s'investir dans la riposte, je leur proposerai de rentrer en contact avec la délégation de la santé ou les districts eux-mêmes pour aménager un ou deux postes fixes de prélèvement dans chaque district de santé. On réglera ainsi les problèmes de stigmatisation parce que quand les voitures estampillées 15-10 arrivent dans les communautés, parfois il y a des personnes qui vous disent qu'elles ne sont pas à la maison parce qu'elles ne veulent pas être stigmatisées. Et également la consommation excessive en EPI. Il faut à chaque fois porter l'EPI et enlever quand on sort de la maison. Alors, si on a un poste fixe, on peut garder le même EPI sur soi pour on en consommera beaucoup moins. Donc, voilà ce que je propose à faire parallèlement à la réouverture des écoles, c'est que le système soit prêt à faire un dépistage précoce des cas suspects.
Thank you so much. I'm sure all the participants are in concert with me about how much enjoyable this webinar has been. I wish all our webinars were like this. Congratulations. Thank you to all the panelists. We've had a wonderful time with you. The Coronavirus Task Force at the Nkafu Policy Institute is at work, and we want to see things change. If you would love to join us to brainstorm, to develop policy, to strengthen our research endeavors, you are welcome. If you would love to come in to bring assistance to the healthcare personnel or communities, and you would like us to propose how that can be done, you can contact us. We are so happy to have had all of you. We're sorry for all the questions that we've not been able to take. We'll have another webinar. We'll still invite all of you and hope that you will be able to join us. That said, we are at 4 p.m., exactly 1 hour into the webinar. And I want to say thank you for coming. God bless you, and we look forward to having you some other time. Thank you.
Thank you, and together we'll come out stronger.
Thank you so much.